Welcome to Credentially Podcast, your HR healthcare kit.
Hello.
Hi there, how are you?
I'm good. How are you?
I'm good, thank you. What we're trying to do on the Credentially Podcast is talk to experts in the field like yourself, help to gather and to share insights about medical workforce and about trends in the industry, and really just find those interesting bits of information that are sort of counterfactual or that not everybody knows. So with that, I'd like to thank you very much for taking the time to speak to us. And if you'd be kind enough to introduce yourself.
So my name is Tjasa Zajc. I'm a business developer at a healthcare IT company, Better. I'm a patient advocate. Most people know me as the founder and host of Faces of Digital Health, which is a podcast about healthcare digitalization and healthcare systems across the world. The show has been running for almost 6 years with over 220 episodes published so far. And the reason I started this was because I've been a chronic patient for over 20 years. I did a master's degree in healthcare management and economics and worked as a healthcare journalist full-time for several years before moving into the healthcare IT industry. So that's in short.
Wow, a tremendous success with the podcast ever started in terms of sort of volume. So 220 must put you in sort of very rarefied air. That's a great number of episodes. Well done. 6 years. It's quite an achievement.
Yeah, it's a lot of work, but it's also very gratifying to get a lot of insights and to be able to share these insights with the audience to just expand the state of healthcare across the globe. I really do believe that by sharing ideas, by sharing thought leadership and understanding how people from different cultures think, how they solve problems and what kind of problems they are faced with in the first place, that by sharing that we get new ideas. And healthcare has more problems than we have solutions for. So we still have a lot of work to do and a huge need to put a lot of effort into solving healthcare issues.
Yeah, absolutely. And healthcare, it's interesting, isn't it? It's literally a life or death sort of business that or profession that people are engaged in. But actually, when you look at the state of technology in healthcare, often it sort of lags behind other industries like online retail, like gambling, like gaming, for example, in the use and spread of technology or best practices from industry. And it can sort of have a legacy of being quite a hierarchical and almost sort of militaristic organization in a sense. You know, in the UK, for example, training doctors are still called officers, house officers, senior house officers. And there's that sort of legacy of it being sort of a pretty old school profession. So I think anything that can be done to share those best practices across industry, aggregate information, particularly when it comes from other industries, right? And can bleed in and lead to new changes in working practices and make healthcare more efficient is very worthwhile. So yeah, congratulations on what sounds like a really amazing podcasting career so far.
Mm-hmm. If I just make comment quickly, you mentioned one very interesting thing, and that is that healthcare is very structured, very robust, and very rigid in terms of changes. And you said that doctors are still called officers. And I just wanted to say that just the structure and the language that is that we use in healthcare is something that has a lot of need for change, because the way we express ourselves also impacts the way we think about what we do and the people that we work with. So, for example, another problem related to linguistics is how we talk about patients. You know, patient denies pain, patient smoking, patient denies smoking. You know, the patient failed the treatment. So that's very unempathic. And I guess, you know, from the doctors or the workforce perspective, just knowing what are the ranks of where you are in your clinical career can potentially hinder the interest that people have about healthcare once they're in it. Because a lot of people come into healthcare with this really noble idea that they're just going to help patients, that they're going to save lives. And then they get disillusioned because work is repetitive, the structure is too rigid, there's not enough collaboration because of the hierarchy, and sometimes there's just this impression that you have to do what you're told to do, not enough teamwork. These are, for example, some of the complaints or critiques that I hear when I talk to people about healthcare and healthcare workforce.
Yeah, I think that's very interesting. And as you say, people do often go into healthcare with noble motivations, and certainly not just for doctors, although many doctors are underpaid in many countries, but often for people like healthcare assistants, nurses that are doing very important work. The pay that they receive compared to the stress that they face, the nature of the work that they do, the burden of responsibility that they carry, isn't really commensurate. So, you hope and you have to assume that there's a real level of duty and of sort of a moral imperative to do what they're doing. I agree. I've seen that effect. We call it burnout, but when people can get to this level of depersonalization where the work becomes too stressful, they have to do the same thing too many times. They feel that no matter how many patients they treat, that they'll still see the same cases day in and day out. And that language that you correctly identified as sort of disempowering, even calling patients rather than sort of clients or service users, is something that's sort of being addressed in the UK now to try and make healthcare less of a hierarchical thing where you, as someone that knows nothing, goes to someone that's trained and speaks Latin and refers to you as a patient and describes you as you say, denying doing things that we secretly suspect you've done, like smoking or eating unhealthily, rather than kind of engaging with you in a more collaborative manner to have agency and to take care of your own health, I think is a good change and something that needs to happen in the industry. I'd like to ask, do you think that during COVID, there has been a bit of a change in that dynamic? We've seen an explosion in people seeking on-demand care. So trying to find clinical care when they need it, often remotely via the internet, and doing so more as a client, that in the same way that they'd purchase any other good or service, rather than sort of in more of a traditional hierarchical role. Have you seen an expansion in that?
Mm-hmm. So as a general observation, I would say that several things happened during COVID. One was that a lot of medical workers got sick, so the workforce shortages had an even acute state. So it was even a higher or more important problem than it was before. Secondly, the need for the workforce stronger. So on the one hand, you had less healthy people, and those that stayed in healthcare had to work more. And what was the consequence of that was that suddenly, this was a really kind of good opportunity for some of the workers to just go to places that were prepared to pay more for their salaries. So now the expectations about what the payment is supposed to be like or should be like has changed because of the pandemic. The second thing that happened was that exactly because the working conditions worsened, the expectations of people regarding how much they're willing to take when it comes to their job has changed. And unfortunately, many people left the profession either completely or they moved to the new models that also spurred out during the pandemic. So telemedicine became something that's used on a daily basis for a while. Like today, we see that all the insurance policies that were reimbursing telemedicine the same way as in-person visits in the US have been reverted. So a lot of things are going back into the doctor's office. But what I think hasn't changed is that digital health in general is still growing in terms of investment. We've got new companies, or the existing companies that saw the potential in telemedicine really got a lot of investment during the pandemic. So they were also able to maybe employ more clinicians that previously potentially didn't even think about going into telemedicine. And now we had the option of working from home more. And, if you work in medicine where you are constantly working long hours on a weekly basis, don't have a nice quality of life or contact with your family, suddenly shifting to that at home office mode where you've got your family in the next room. I can see how that is appealing to some people. And, if many workers that work in professions that allow for remote work and the benefits that come with that, obviously, I don't see why doctors wouldn't have the right to feel good about having that kind of a model, or a hybrid model where they work part-time in the clinics and part-time from home, from telemedicine providers. A few things that I've heard from just hospital managers is also that just because of this shift in the expectations around the workplace, it's actually getting harder and harder to get enough people to work for a hospital or healthcare provider full time. And that means that they have to hire agency or contract workers, which are much more expensive than the people that are employed full time. So it's, I think the disruption in healthcare in terms of workforce hasn't stopped yet. And we'll see where it goes.
Yeah, I agree. I mean, certainly something that we encounter a lot when we talk to American healthcare providers or people that are familiar with the North American market is sort of the explosion in travel nursing. So nurses that previously would be employed full time, then moving to work for agencies and be brought in to cover sort of a pattern of shifts, maybe a week, maybe a few weeks in a ward or facility that otherwise would have to close because they would have unsafe staffing levels that are paid, often multiples of the salary that they could previously earn, often working in the exact same place or in very similar roles. And now the sort of expectation that's set about sort of, yes, rates of pay, but I think also flexibility. I think the other thing that medicine has been quite poor at doing is adapting to the fact that many people that go into medicine themselves, because of their often caring nature, have caring responsibilities, right? So they're caring either for elderly parents, they're caring for young children, that unless those people can be accommodated and allowed to work flexibly, often they're forced to leave the profession for a time. Certainly, often we see in the UK, people leaving during what can be quite a long postgraduate training process to raise young children, and then having to make a decision, do I come in, do I restart that training process, which often isn't easy, or often they'll have to start at the beginning again. Or do I not sort of go on to do what I maybe would have been able to in achieving a higher specialization, often in roles where we badly need those specialists. So I think, yes, accommodating people's ability to work flexibly and to take care of their own caring responsibilities is necessary and ultimately gives us a larger pool of medical workforce. But I can understand how, if as a facility you had, let's say, 10 doctors covering a full-time rota doing 40 or 60 hours a week, and now all of a sudden you have to do 40 that are doing, 10, 15 hours a week. That's much more work from an onboarding, recruitment, compliance point of view to treat the same amount of patients effectively. And equally, if those people are expecting now higher rates of pay, either because they're sort of agency staff and they've gotten used to that, or they have other options, better options, perhaps with telemedicine providers, I can really see how that dynamic's changed and how that could be hard for healthcare providers.
There's several challenges and it's complex to change the appeal of healthcare. And this brings us back to what we were talking about earlier, and that's the legacy that healthcare structure has and the way it's organized. Until it's hierarchical and until we've got workforce shortages, how can you start changing a culture when you've got an abusive consultant that just intimidates junior doctors? Leadership of the hospital is supposed to do, if that's potentially the only consultant for a specific specialty in the hospital, it's not that easy to just say that you will fire someone, or think what kind of sanctions can you actually implement, or encouragements to change the culture. That's the big issue, I guess.
That's right. And I think it can become a negative spiral often, where those toxic work environments lead to increased vacancies. I was speaking to a very senior, very good nurse that's working in a hospital that's really struggling in parts of the UK that has a very high rate of turnover of staff. And they feel terrible about the fact that they want to leave because they know this place is going to struggle to replace them. But after a certain point, things can get so bad in a department, in a ward, that these sort of, and particularly if healthcare workers are scapegoated, right? There was a campaign in this country called Learn Not Blame to deliberately move away from blaming individual clinicians for what very frequently are systemic risk factors that lead to mistakes being made inevitably if you run the cycle enough times. If you have too few staff chronically, if those staff aren't supported with the right tools, if you don't have automatic warning systems in place often, then it is inevitable that those human mistakes will be made. And if the systemic risks of those aren't addressed in the way that they are, for example, in the airline industry, where you always have a root cause analysis after there's an accident, after something bad happens, then you end up with an individual scapegoated, and all the other individuals working in that organization see, I too will inevitably make a mistake because I'm human and I'm working in an environment that's very challenging, where I'm maybe seeing more patients than I should be doing, maybe working longer hours than I should be doing. And what's going to happen to me when that happens? Often it's certainly the risk of losing livelihood, right? But in this country, clinicians have faced the threat of criminal prosecution for, again, not mistakes of sort of deliberate malevolence, but mistakes that happen in the same way that we all make mistakes. We all lose our keys, we all drop things. But if you're treating a greater number of patients than you're supposed to be treating, and the ward that you're in is understaffed, the systems that you're relying on to, say, get phlebotomy or biochemistry results aren't working, so you're not notified if you get a bad result, then it to a degree becomes inevitable that those mistakes happen. And if the staff lose confidence that they'll be supported, and that rather than them being treated as a scapegoat, those root causes will be addressed, which often, the fundamental reason for them is resource constraint, right? Often healthcare is delivered in a condition of extreme resource constraint. Then it kind of adds to this toxic culture of people just not wanting to do it anymore, or wanting to change the power dynamic. And that's something I think that telemedicine companies and that agency work can certainly offer, is a real change in that power dynamic between the provider of care and between the clinician.
Mm-hmm. Yeah, I would agree. And this is where technology can help to a certain degree. There's a lot of really good solutions that are addressing patient safety, but still you have to have a good team and you have to have funding to be able to afford that. And more importantly, one thing to emphasize here is that technology usually doesn't work on its own. You have to know how to use it. So you, again, need additional time for the staff to be trained so they can reap the benefits of new technologies. And that's very difficult if you are already understaffed and are literally dealing with 10 ambulances waiting in front of the hospital to admit patients. It's, I guess, time management and challenges in how are you going to determine what is the best time to teach staff is a little bit more complex than perhaps in some other companies or industries.
Yeah. And certainly if you're running an acute service, in accident and emergency or sort of emergency medicine, because you're running a 24-hour service that often cannot close because there are sort of no other places to take that patient if that particularly, or take them in a reasonable time period if that closes, then even just changing the clinical system, when do you do that? It has to physically happen at some point. There has to be a changeover. Those people need to be trained. But as you say, we frequently in this country now have a queue of ambulances outside departments that are waiting to discharge their patients into the department. The paramedics are having to leave patients in those ambulances often for quite a while. because there's no beds in the A&E department, because there's no beds in the hospital. Under those circumstances, it's great to have technology that can make people safer, often clinical tools, or that can provide productivity improvements. But if there's no slack in the system, it's very difficult to think about when you would implement them or when you would train people to use them. So yeah, I completely echo what you're saying.
That's why I think it's really important to emphasize over and over again for decision makers that just addressing workforce shortages in healthcare doesn't mean that you need to change the rules in terms of or just lower standards in terms of who can study medicine or nursing. You need to change the working conditions because, even if you do increase the number of people that would be qualified to work in healthcare, if they come into healthcare and the situation is bad and they leave because it's the working conditions are unacceptable, then you didn't solve the problem. You have to make the profession appealing so people will be interested in and treated better, and therefore interested in staying in the profession longer.
Yeah, I completely agree. And I think when I look at the year that I studied medical school in and the people that I've kept up to date, the number of people that are still practicing full-time in the UK's National Health Service is, as a percentage, a lot lower than I would have expected. And I understand from people that I've spoken to that that's a national trend, which is concerning because already as it is, we rely on the import of clinical professionals from other countries to make up for a structural shortfall that we know we have in the number of people that we train versus the number of people that we need. And so if we're not even retaining those that we do train, knowing that that has a shortfall, then it's a real indictment on the system. So, but we talked a lot about sort of doom and gloom, and I think everyone has an idea of how hard things have been for the profession and for the industry in sort of during COVID and a post-COVID world. I'd be really interested to hear what you've seen as sort of bright spots. So where have you seen things improving or kind of flowering, or where are you seeing kind of best practices take hold? And what are the learnings that you'd like to share that you think either providers or clinicians can implement to make their own lives or patients' lives or the efficiency of their facilities better?
Well, I might just point to one trend that has been happening in the US mostly, but it's been quite a few years now. But there's quite a few organizations that really encourage entrepreneurships among nurses. So nurses are, just getting a seat at the table, innovating things that would be good for the nursing profession. I think that's something that we perhaps didn't see 10 or 15 or 20 years ago. So that's, I guess, the bright spot. Another bright spot, I would say, is that to a degree, when people move outside of healthcare, part of them does go to the digital health industry or to the tech giants, because you can't create solutions without the clinical input or the input of the workers. And I hope that, if there are more people that create solutions that are really, that really make a difference for the users, either clinicians, nurses, pharmacists, then, slowly we can get to the change that we were talking about before. So the change in the way things are done, the efficiency, the care that you can provide, even perhaps with a smaller number of people, because those people can be more effective in the work they do. And that could slowly lead to a healthcare improvement if a cascade of positive things happen because of that change.
I think that's a really good insight. And the thing that I like about it is it's potentially scalable. If someone comes up with a technology that can be scaled, that is based on their clinical insight and can be rolled out sort of system wide to help. It's something actually that the United Kingdom has done quite well. They have a program called the NHS Clinical Entrepreneurship Program, led by Professor Tony Young, who himself is an entrepreneur, also a consultant urologist. And he has a program to sponsor clinicians that have ideas for things that could be used typically to improve medical practice or care. And often those people, like myself, would sort of stop medical practice at that point and then work full time to try and bring that idea to fruition, because it's a long, difficult journey. Or they'd be poached by industry and they'd work for a large company. And his program is designed to support those people whilst they still retain their training number or retaining their training posts, and to ensure that those innovations get to market as quickly as possible. And they've done some really interesting things. So they're sort of working on automated drones, for example, to fly hematology deliveries around the country. There's been some very cool projects come out of that. And I suppose the history of medicine is littered with clinicians that would have an idea for a tool that was necessary, like the Thomas Flint, for example, very basic, but to stop a fracture or a fractured leg from causing the patient to die of blood loss just by stabilizing it. A lot of those early innovations were created by clinicians. And I think with the first wave of digitization of healthcare, we really got away from that. And systems were designed by engineers, by software programmers who didn't necessarily realize if you have a common operation like ordering a blood test that takes 15 clicks and 5 minutes versus 3 clicks and 1 minute, then the cumulative effect of that system wide is enormous. And so, I agree. I think the more influence that clinicians have over the tools that govern their working practice and over inventions or innovations that can be brought to bear on medical practice, the better we'll all be as sort of patients and people working in healthcare.
I agree. And in that perspective, I think we can learn a lot from countries such as US and Israel, where you've got university health clinics which have venture arms. So they encourage the doctors, nurses to innovate. And if there's an innovation that is potentially scalable, they can spin it out in a startup, and the hospital gets a part of the ownership of the new company. But it encourages people to think about, it's not even about thinking about what you can do to improve the system. It's even perhaps more important to know that you have the opportunity and the power to actually impact something. Because I think for many people, that's the worst thing, that, the system is too rigid and you feel like you don't have a say in it, that nobody wants to listen to what you think could be done differently, and eventually leads to dissatisfaction and potentially the change of a profession.
Yeah, and I think it probably does that most in the people that are very high agency, very creative, that are likely to have those ideas. They're probably people that are most dissatisfied by being in those roles where they feel like they're not listened to, they can't impact a system that they see to be inefficient or broken in some way. And it's probably those people, sadly, that without that support are driven out of the profession first. So I agree with you. I think having them supported, and often, as a clinician, you develop a great degree of skills, but commercializing an early stage technology, particularly if it's a hardware product, is a very difficult journey, and it requires a lot of specialist knowledge, everything from sort of capital raising to getting things through the appropriate certification and licensing that can be aggregated well in a hospital, in a university. But to expect an individual to gain all of those skills themselves and maintain their clinical license and practice hours it happens, but it's a huge undertaking. Whereas if they can be supported from the start, then I think, again, we all stand to benefit greatly. Well, fantastic. Tjasa, I want to keep to the time that we agreed. I'm extremely grateful for you taking the time. It's been a really interesting conversation, something I think that our audience is really going to like. So on behalf of myself, the Credentially team, and our audience, I'd like to thank you very much. If you'd be so kind as to tell our audience where they can reach you and find out more about your podcast. I'm sure they'd love to listen. It sounds like there's a great deal of content there.
Yeah, there is a bit of content.
20 episodes is a lot.
Yeah. So you can find the recaps of the shows by going to facesofdigitalhealth.com, or just search for the podcast anywhere you listen to the podcasts. You can also find me on LinkedIn and Twitter. Great.
Yeah, and we'll share those. So once again, I'd like to thank you very much. I hope you have a wonderful rest of the day. It's been a pleasure talking to you.
Same to you, and good luck with your future endeavors.
Thank you so much. I really appreciate that.
Thank you. Take care.
Bye-bye.
Bye.
Search Credentially for your current healthcare staffing insights.